Hello, everybody. This is Grand Rounds case study number 10. Let's start with the patient history of present illness. This is a 60-year-old male with past medical history of COPD, diabetes mellitus type 2, hypertension, and right inguinal hernia presented with complaints of fever, chills, cough, which started approximately 3 days ago. The symptoms have been progressively worse over the past day and now includes dyspnea. His oxygen saturation room air was 70% on presentation. The past medical history of this patient is COPD, diabetes mellitus type 2, hypertension, surgical history, right lung biopsy in 2013, right inguinal hernia repair in 1997, bilateral cataract removal. For the family history, maternal diabetes and hypertension, paternal diabetes and congestive heart failure. The patient has no known drug allergy, with social history of married with 2 children, resides with family, remote history of tobacco use, quit 5 years ago, positive for alcohol use, negative for illicit drugs. Home medications, theophylline, Spiriva 1 puff every day, Dolera 2 puffs BID, Ventolin HFA, amlodipine 5 milligrams PO daily for his hypertension. For the review of symptoms, the patient complains of fever, chills, fatigue, and general body weakness. No recent weight loss. Patient has positive congestion with running and sore throat. No visual loss, blurred vision, double vision, or yellow sclera. No hearing loss. For the skin, no rash or itching. Cardiovascular, no chest pain, chest pressure, or chest discomfort. No palpitations or pedal edema. Patient has positive shortness of breath, cough, and sputum production, no orthopnea or paroxysmal nocturnal dyspnea. For gastrointestinal, no anorexia, nausea, vomiting, or diarrhea, no abdominal pain or blood in stool. Genital urinary, no burning upon urination, no urinary frequency or incontinence. The musculoskeletal is positive for joint pain, no muscle pain, complaints of back pain or stiffness. Hematologic, no bleeding or bruising. Lymphatics, no enlarged lymph nodes. Neurologic, no headache, dizziness, syncope, no numbness or tingling. Psychiatric, no depression or anxiety. For the endocrine, no reports of sweating, no cold or heat intolerance, no polyuria or polydipsia. For physical examination, general, ill-appearing male without signs or symptoms of distress, vital signs with a height of 170.18 centimeters, weight is 80.74 kilograms, blood pressure is 100/61, pulse is 72, respiration is 22, oxygen saturation is 70% on room air, temperature is 37.4 degrees. His head is normocephalic, atraumatic, no lymph node swelling. For the eyes, ears, nose, and throat, perla at 2 mm, oropharynx is clear, mucous membranes are pink, trachea midline. Neck is supple, full range of motion, cardiovascular, S1, S2, regular rate and rhythm, no murmurs, rubs, or gallops. He has positive 2 plus pulses on both bilateral upper extremity and bilateral lower extremities. For respiratory, he has coarse rhonchi on right middle lobe, left upper lobe. He has positive expiratory wheezes, no rales, productive cough, approximately 2 tablespoons thick greenish sputum. For the gastrointestinal, abdomen is soft, non-tender, non-distended, normal bowel sounds in all quadrants, no pulsatile mass, no hepatosplenomegaly. For the musculoskeletal, he has trace edema on bilateral lower extremities, no gross deformities, normal range of motion, no cyanosis or clubbing. For the neurologic, he is awake and alert, oriented to person, place, and time. Integument, no rashes, PTK, or purpura. For the psychiatric, he has normal affect. The X-ray shows mild non-specific perihilar alveolar interstitial edema, left greater than right. No focal airspace disease, no pneumothorax or pleural effusion. The CBC is showing an elevated WBC, which is 14.1. The rest of the results are unremarkable. The CMP shows glucose, which is elevated at 153, and a magnesium level of 12.7. The rest are unremarkable. The rest of the laboratory test shows that the lactate, which is elevated at 3.6, respiratory panel is negative for viral infection, MRSA nasal swab is negative, blood cultures are still pending. My diagnoses are community-acquired pneumonia, COPD exacerbation, and hypermagnesemia. For my differential diagnosis, pulmonary edema, lung cancer, pulmonary infarction, pulmonary embolism, and acute coronary syndrome. For CAP, which refers to an acute infection of pulmonary parenchyma acquired outside of a hospital, the epidemiology is it occurs to older adults with comorbidities, which are recurrent upper respiratory tract infection, COPD, and diabetes mellitus. For the signs and symptoms, in the pulmonary, cough, thick greenish sputum production, shortness of breath, dyspnea, hypoxia, pleurisy, rhonchi on auscultation. For systemic signs and symptoms, fever, chills, leukocytosis, generally they present with fatigue, general weakness. And X-ray shows usually with infiltrates. For the diagnostics in hypoxia, I have AC2E as an acronym, which is ABG or VBG. CBC, we can also do BMP, ESR, CRP, procalcitonin, lactate. Chest X-ray or CT of chest if chest X-ray negative and no cause identified. We can do also ECG if it's positive or negative with troponin and BNP, and we can do sputum or blood culture with RSVP, influenza, or COVID-19 testing. The management of CAP is oxygen administration, maintaining SpO2 goal of 92%. The mainstay therapy is antimicrobials, wherein you need to modify the regimen for Pseudomonas risk factors or add to the regimen for MRSA risk factors depending on your blood cultures. Examples of beta-lactams are ceftriaxone 2 grams IV every 24 hours for 5 days, ampicillin sulbactam 3 grams IV every 6 for 5 days, in addition to a macrolide or fluoroquinolone or doxycycline. Example of macrolide is azithromycin 500 mg PO times 1 on day 1, then 250 mg PO every 24 hours for 4 days. Fluoroquinolone example is levofloxacin 750 mg PO or IV every 24 hours for 5 days. Moxifloxacin 400 mg PO IV every 24 hours for 5 days. Or doxycycline 100 mg PO or IV every 12 hours for 5 days. For COPD exacerbation, clinical features of COPD exacerbations are increasing cough, shortness of breath, wheezes, reduced exercise capacity, hypoxia, and hypoxemia. Diagnostic testing can be spirometry, chest X-ray, ABG, alpha-1 antitrypsin deficiency test, CBC, wherein hematocrit increases in COPD exacerbation. Management can be bronchodilator nebulization, which is salbutamol 5 milligrams every 4 hours, ipratropium 500 microgram every 6 hours, Controlled oxygen therapy, if SaO2 is lesser than 88%, we can give steroids, which is hydrocortisone 200 mg IV, home oral prednisolone if the patient will go home, 30 mg OD for 7 to 14 days, which needs to be tapered down, then stop ultimately. Antibiotic therapy if with infection, aminophylline if no response to nebulizers and steroids. Remember that hypoxia drives respiratory center in COPD patients. For hypermagnesemia, hypermagnesemia is an uncommon electrolyte disorder. With mild, usually patients are asymptomatic. However, majority of them have muscle weakness, nausea, dizziness, and confusion. For moderate, there are decreased reflexes, worsening state of confusion and sleepiness, bladder paralysis, flushing, headache, constipation. For severe hypermagnesemia, has a muscle flaccid paralysis, decreased breathing rate, more evident of hypotension and bradycardia, prolongation of PR interval, lethargy. The evaluations are serum magnesium level, BMP focusing on renal biochemistry, ABG, clinical evaluation of renal function with urinary output, potassium phosphate, calcium levels in plasma or urinalysis, and EKG. Management. Patients with normal renal function and no symptoms require no treatment. Severe cases require close monitoring of the EKG, blood pressure, and neuromuscular function. Early treatments are intravenous calcium gluconate or chloride for cardioprotection, intravenous normal saline 150 ml per hour. Severe clinical conditions require increasing renal magnesium excretion through IV loop diuretics, which is furosemide 1 mg per kilogram body weight, hemodialysis when kidney functions are impaired. This is the end of my presentation. Thank you for watching, and let's go to the discussion portion.